Now we'll move to the last speaker, Dr. Zayana Al Hadrami. She's a transplant nephrologist at Sultan Qaboos University Hospital. Actually, I think she's going to address a very important topic, and it should be implemented in each transplant program about the woman health and kidney transplantation. Please, Dr. Zayana.
Good afternoon, everyone. And thank you for the organizing committee for giving me this opportunity to present today, and welcome to the last talk of the day. So I'll be talking about women's health and kidney transplantation. And the outline of my presentation today will be about women's health as a kidney recipient and as a kidney donor. I will be covering mainly reproductive changes in transplant, pregnancy, and breastfeeding. And about a woman as a kidney donor, will be focusing mainly on pregnancy outcomes. So we'll start with a few facts. So women are more likely to have chronic kidney disease than men, but men are more likely to end up with end-stage kidney disease requiring dialysis. Women are less likely to be listed in kidney transplant to be listed for kidney transplant. However, if they are listed, they're more likely to wait for transplantation. And women are more likely to be kidney donors, but they are less likely to be kidney recipient, whether from a deceased or from a living donor. And these facts are not necessarily because of the inequity or gender inequity, but rather because women are more likely to have autoimmune diseases, more likely to receive blood transfusions. They are getting more likely to get pregnant. However, all of these factors, they make them more sensitized and more challenges to receive a kidney transplant than men. So we'll focus now on reproductive changes in CKD patients, mainly females in this presentation. So we all know that CKD females are more likely they are having loss of menstrual abnormalities or irregularities. Almost 90% of females on dialysis have either absence or irregular menses. They have premature menopause and infertility. And the main reason for that, or main explanation for that, is the hyperprolactinemia. We all know that prolactin gets cleared by the kidney, and in advanced CKD dialysis patient, prolactin accumulates, and prolactin will inhibit the gonadotropin-releasing hormone, which will lead to disturbance in the hypothalamic pituitary gonadal axis. So this will lead to irregular cycle or an infertility. Another explanation for that is that if you compare a normal female, I don't know if there's a pointer. If you compare a normal female with a CKD or dialysis patient, a normal female will have a surge or in LH, FSH, and gonadotropin-releasing hormone, which are all secreted in pulsatile manner. However, in CKD and advanced CKD and dialysis patients, GnRH, LH, and FSH are secreted in a non-pulsatile manner or a constant manner. And this is also similar to ladies who have menopause. However, the difference is when you have this pulsatile manner in a normal patient, this will stimulate the secretion of estrogen and progesterone from the ovaries. When we don't have it, this will decrease the production of estrogen and progesterone, and this will lead to non-ovulatory cycles leading to secondary menopause or early menopause. The fortunate part of it that all of these abnormalities in the hypogonadal axis disappears or are very reversible after kidney transplant. There are lots of observational studies that looked into the differences before and after transplantation. I just quote a few examples here where they actually trace the prolactin level, estrogen, progesterone before and after transplant. And you can see in the graph on the right side there that they checked the prolactin level few hours before transplant and how dramatically it dropped even within few hours after transplantation. And just showed you how kidney transplant changed the female's life, not just the health life, but also the reproductive life of these young females. So because this is very reversible, kidney transplant patients are more likely to get pregnant, even compared with other solid organ transplantation. So if you compare them even with liver transplant, combined kidney, liver, or heart and lung transplant, kidney transplant recipients are more likely to get pregnant and with successful live pregnancies. Most likely because most of these patients who have heart and liver, pancreas transplant, they are more sicker, and there are lots of complicating factors, and they maybe use more immune suppressants compared with the kidney transplant alone. So because of this quick reversibility of hormonal changes and the quick ability to become pregnant within weeks to months after transplant, it's important to counsel these patients about the appropriate timing of pregnancy. And according to the American Society of Transplantation and the European Society of Transplantation, they came up with a consensus of what's the best time to counsel this patient to become pregnant. And the criteria that they should meet to give them the green light to get pregnant, it has to be at least 1 year post-kidney transplant with a stable graft function. And the definition of a stable graft function varies, but really most of the guidelines define it as a creatinine less than 1.5, which is 133 millimole per liter, with no or minimal proteinuria. And they came up with this from this study where it was a systematic review and a meta-analysis of 50 studies, where they found that hypertension, a creatinine of more than 133, and proteinuria were the major predictors of adverse pregnancy outcomes. You also need to have no rejection or no episode of rejection in the last year, and no concurrent nephrotoxic infection or nephrotoxic medications. And they should be on a stable regimen of immune suppression with the lowest possible doses. So while these patients carries on during their first year post-transplantation, we really need to cover the topic of contraception, and this topic should be actually discussed prior to transplant when you see them for the first time on kidney transplant assessment clinic. So according to CDC, the criteria, so they came up with an eligibility criteria for common medical conditions, including solid organ transplant. And they graded the contraceptions as 1, no restriction; 2, benefit outweigh the risk; 3, risk outweigh the benefit, but safer than getting pregnant; and 4, an acceptable risk. And I know we as nephrologists, we don't deal with this a lot, but we own these patients when we follow them before and after transplant. So we will be the one who will be counseling these patients more than an obstetrician. So it would be good to have some idea about contraception advices. So according to the CDC criteria, this is a busy slide, but just to showing you that solid organ transplant was part of the common medical conditions listed. And they basically divided the contraception into complicated or uncomplicated graft function. So the definition of complicated graft was based on the CDC criteria is a patient who had an episode of acute or chronic rejection. But really it could be anything of any uncomplicated course of transplantation. So according to the CDC, if this transplant was uncomplicated, so the patient may use any form of contraception, so the benefits weigh out the risk. So basically, they could use an IUD device, whether hormonal or copper, combined hormonal, oral progesterone, injectable or implantable device for progesterone. And even if they have to use the combined, which will contain the estrogen, then usually we avoid it in the first 6 weeks post-transplant just because of the thrombotic property of estrogen. And then they have to use it 6 weeks post-transplantation. If the transplant was complicated, then the CDC graded combined hormonal contraception as grade 4, where the use is restricted. And this is mainly because estrogen, as I said, is more prothrombotic and more likely to lead to hypertension. Here they listed the intrauterine devices as grade 3, where risk outweighed the benefit, but really the evidence is weak here, and it comes from few case reports of young female getting pregnant while they're using the IUD device. And they attributed this because of the immune suppression medication they're using will decrease the efficacy of intrauterine devices to produce an inflammatory process to inhibit the pregnancy implantation. However, the evidence, as I said, is weak, and we did see lots of patients who on IUCD with successful contraception. Regarding progesterone-containing medication, including Bell's implantable devices or injection, they are the most common used in complicated transplant. However, there is also the risk of osteoporosis, and that has to be looked at carefully and followed carefully in these patients. So when you have a patient who had a kidney transplant and met the criteria or she's ready to become pregnant based on the criteria from the Transplant Society of America and Europe, then you have to look into a few things and follow these patients closely and monitor closely. So things that you need to make sure before, as a pre-conception care, is make sure that they are on the minimal immune suppression with no or at least side effect, appropriate timing to switch immune suppression that we'll talk about shortly, and ensure that the stability of graft function. Make sure that you add them on antenatal vitamins and folic acid. Make sure that the blood pressure and diabetes control is under control, and they will need close follow-up by both nephrology, transplant nephrology, and high-risk obstetrician. So this is a busy slide. Was just showing the importance of knowing the side effect of all the transplant medication, which one is teratogenic and which one you need to stop and when you need to stop. The most important ones that you need to discontinue prior to transplant is mycophenolic acid, graded as grade D, and that has to be stopped at least 4 to 6 weeks prior to transplant. And this is because of the highly teratogenicity effect of mycophenolic acid, basically congenital abnormalities, including cleft lip, cleft palate, lip and agnesia, and also esophageal and tracheal atresias. So these need to be stopped, and it also present in a very high quantity in breast milk, so it also has to be discontinued during breastfeeding. Regarding sirolimus and everolimus, they are graded at grade C because toxicity has been seen in animal studies, but really we don't have any human studies that prove that they are teratogenic. Even the animal studies one showed that these medications are available in high or toxic levels in animal fetus, but they didn't see any teratogenic effect. But because the data is still limited in human, they should be discontinued again at least 6 to 12 weeks before conception, and also they should not be used during breastfeeding. Again, the evidence behind belatacept is very weak because we don't have good evidence and data behind it. Although some observational studies included 16 pregnant ladies used belatacept during pregnancy with no side effects. However, because we don't have the good evidence behind it, it's recommended not to use it if the patient is planning pregnancy. And again, because there is no limit data on breastfeeding, it should not be used before breastfeeding. The list below there is the medication that you can use, including steroid, except that you need to make sure that this is not in a very high doses, because there is also some reports of congenital anomalies, especially cleft lip, in high-dose steroid. But we can still use steroid in pregnancy and breastfeeding. Azathioprine is a safe medication during pregnancy, and it's usually the one that we switch myfortic or sirolimus everolimus to it. And again, the switching has to be at least 6 weeks to 12 months before contraception, and you have to make sure that the graft is stable while on this new regimen. And it can be used for the amount of azathioprine available in breast milk is very minimal, so it can be used safely during breastfeeding. Tacrolimus and cyclosporin, again, can be used safely during pregnancy, although it was found that they are available in the fetal blood with an amount that's not toxic enough, but there are cases where there is hyperkalemia and AKI in fetus patients. However, the experience and observational trials showed safety and no teratogenicity, so we still use it. Another consideration you have to keep it in mind is that these medications are highly protein bound, So the levels will be very variable during pregnancy, so you might need to increase the doses during pregnancy. So this is for two reasons. One, because the plasma volume increases, and two, and these patients are more prone to become hypoalbuminemic. So the total tacrolimus and cephalosporin level in the blood will be low. However, we don't have data on the free tacrolimus level because unfortunately we don't measure that. So these are the drugs that you can use during pregnancy and during breastfeeding. What about medication we use for rejection? Fortunately, this is not happening that frequent, as we will talk about later, but really if the pregnant patient have acute rejection episode, we don't have lots of options. All what we can use is steroid and IVIG if this is an antibody mediated. However, ATG or antithymocyte globulin antibodies and rituximab are contraindicated during pregnancy and breastfeeding. In fact, if you use rituximab, you have to wait at least 6 months to make sure that the effect of the drug is out from the system. So we'll talk now about the outcome of pregnancy in transplant patients. And I have to stress here that most of these data coming again from observational trials and registries from US, New Zealand, and UK, European countries in general. That's why the evidence might not be applicable here, and we don't know if all the cases has been reported. So regarding maternal outcome, there is lots of observation that transplant patient gets more cesarean section than spontaneous vaginal delivery, although vaginal delivery is not contraindication, and the mode of delivery really has to be guided by the obstetric indication. So there is no contraindication for vaginal delivery, but if they have to go for a cesarean, then the surgeon has to be aware about the anatomy so that they will be aware of the size of the kidney and avoid any injury. Transplant patients, they are more pregnant ladies are more likely to become hypertensive during pregnancy, and this is even compared with liver transplant patients. And this is more attributed to the prolonged hypertension prior to transplant, leading to chronic endothelial damage. And regarding gestational diabetes, again, it's more common in kidney transplant recipient pregnant ladies, up to 8% compared to only 5% for liver transplant and less than 4% for non-transplant control. Regarding fetal outcome, because preeclampsia is more prevalent in transplant pregnant ladies, up to 5 times more than the general population, these babies are more prone to become preterm birth, and also more likely to be of low weight birth. According to this study, actually up to 50% of babies born by a transplanted patient, they have low birth weight versus only 8.1% in non-transplant patients from a US data. IUGR is another complication that reach up to 50% in transplant compared with only 3 to 10% in non-transplant patients. However, spontaneous abortion was comparable between the two groups. Again, this is from a single center, the single registry from United States. What about graft outcome? Again, the data is lacking. However, most of the observational trial studies and most of our clinical practice show that, fortunately, rejection is very low prevalence in kidney transplant recipients who are pregnant, and it's as low as 0.9 compared with 3.4% for liver transplant. And regarding the factors that increases the risk of rejection is preceding hypertension or abnormal kidney function in these recipients. This is a famous graph of how the kidney function act or behave during pregnancy. As you know, that most of the eGFR improved by almost 50% in general population, and the creatinine drops by almost 50. However, we don't have a good data on transplant patients, except for some observational trials. This study was done in UK, where they observed 105 patients during pregnancy and compare the dip of creatinine during the second trimester. They did notice that there was a dip in the creatinine. However, the dip is more subtle compared with non-transplant patients. And the median creatinine before transplant was around 118. It dips to 104, but it went up again. And in fact, 50% of these patients did not show any dip, and the creatinine stayed stable. So you might not expect the usual dip in creatinine and improvement in GFR in transplant population. So what should we do while we are monitoring these patients? These patients should be seen more frequent, every 2 to 4 weeks, especially later from the second trimester onward. And monitoring should be combined by transplant nephrology and high obstetric clinic. And things you need to be looking for is surveillance for their blood pressure, diabetes, kidney function, drug level monitoring, and any evidence of infection. What about women as kidney donors? So basically, the outcome of a kidney donor will be similar to any patient who had a nephrectomy, a regular nephrectomy. However, there's a special situation here when these patients become pregnant. Because we know that there's a significant proportion of females donors are in the childbearing age. So we really need to counsel these patients when we see them in the assessment clinic of what are the complications expected if they become pregnant. So maybe the best data comes from this trial. It was a systematic review and meta-analysis looking at pregnancy outcome in living kidney donors. And it was a systematic review of 5 studies, one from US, Norway, Canada, South Korea, and United States, all of them retrospective observational studies, and with a reasonable number of patients compared with a general population of non-transplant recipients. And they did exclude all the patients who had any risk factors that can prone to or lead to a bad outcome, like diabetes, hypertension, or any previous preeclampsia, for example. So from this study, they showed that the 3 main pregnancy outcome that's more common in transplant patients is, are the preeclampsia, gestational diabetes, and preterm birth. So the odd ratio for preeclampsia is 2.8 in donors versus non-donors, 2.5 for gestational diabetes, and 1.3 for preterm birth. However, if you want to quote a number for during the kidney transplant assessment for these donors, you can always use the absolute risk, increase in risk. So these patients are having a higher risk of preeclampsia by 7.4%, gestational hypertension of 5.4%, and preterm birth by 8.4%. And so these need to be clarified in the assessment clinic, and that's why usually we avoid taking donors in a childbearing age if they didn't complete or there is a plan for future pregnancies. However, if they understand the risk and there is no plan for pregnancies, then they should at least understand the risk or the outcomes. That's it for my presentation. Thank you very much.
Thank you, Dr. Zayana. You really covered the topic comprehensively in a very elegant way. Thank you very much.